All right. So I hope you're not too hungry. We're gonna start with a brief overview of what we'll be covering this evening. So I'll start by discussing what is metabolic syndrome and how does the definition apply in the pediatric world. What do we know in terms of numbers in our local population? And we'll go over the risk factors. And here I'll mention a word about COVID because how could we avoid the topic? And finally, the various recommended interventions, starting with lifestyle modification and including the available pharmacologic and surgical intervention in pediatrics. So before we dive in, let me introduce you to Khalid, a 15-year-old boy, or young man rather, who presented to clinic. He was brought in by his parents because of concerns about obesity and rapid weight gain and some abnormal labs. The parents share that he's been putting on more weight approximately since the age of 5 years. And things have gotten worse in the teenage years, particularly in the past year with the lockdown and e-learning. He has a very sedentary lifestyle. Just like Dr. Yasser mentioned, he's an avid video game player, doesn't move very much. So he's one of our typical kids. So on physical examination, his weight is significantly high, 94 kilos. He has a BMI and a waist circumference above the 99th percentile. His blood pressure is borderline or rather elevated, 130/81. He has significant acanthosis nigricans around his neck, and his hemoglobin A1C is also elevated at 5.9%. So what is metabolic syndrome? It's really a multiplex risk factor for cardiovascular disease, including stroke and type 2 diabetes. So the definition of the American Heart Association for metabolic syndrome has identified 6 components of the metabolic syndrome that related to cardiovascular disease. So first, we have the abdominal obesity, the atherogenic dyslipidemia, raised blood pressure, insulin resistance plus or minus glucose intolerance, and a prothrombotic pro-inflammatory state. So in the adult world, the definition is pretty standard, and you need 3 out of the 5 criteria below: high waist circumference, high triglycerides, low HDL, an elevated blood pressure, and a high fasting glucose. Things are a bit less clear when we move to the pediatric population, because simply the predictive risk of metabolic syndrome is different in the pediatric age group compared to the adults. And in pediatrics, we have a myriad of definitions for metabolic syndrome. These are a few that I have up there on the slide. And the problem with it is really how do these definitions, which definition kind of predicts best the risk of developing cardiovascular disease. And so the prevalence will vary depending on the definition that is used, and also whether a child who is defined who fits the metabolic syndrome criteria in childhood may not always fit them in adult, especially when it comes to the insulin resistant part, because we know that insulin resistance can increase during adolescence period, but may improve after adolescence and into adulthood. So one of the definitions, for example, from the International Diabetes Federation, cites that you need to have central obesity plus 2 out of 4 criteria, including a high waist circumference, a high blood pressure, high triglycerides or low HDL, and an impaired fasting glucose. There are other definitions, for example, the one the one that you see right after, which uses pretty much the same criteria, but here the definition is more based on age-related percentiles rather than absolute numbers or absolute cutoffs, and also takes into consideration not only the fasting plasma glucose, but the HOMA-IR as well as an index of insulin resistance. However, all the definitions agree that the main components of pediatric metabolic syndrome are central obesity, insulin resistance, dyslipidemia, hypertension, but there is more and more attention that is being brought to other components, such as non-alcoholic fatty liver disease, hyperuricemia, sleep disturbances such as snoring and sleep apnea. Therefore, the recommendations of the American Academy of Pediatrics is that each of these components should be recognized independently as a cardiovascular risk factor and treated individually. So what do we know about our local population? This is a study from 2015 that looked at the prevalence of overweight and obesity in the world in 195 countries. And as you can see, the UAE actually ranks number 9 in terms of obesity prevalence. And unfortunately, with the exception of the USA in number 2 and New Zealand in number 10, all of these countries are in our region in the Gulf and Mediterranean area. One other thing worth noting is that also in the majority of these countries, the prevalence is much higher in the female population compared to the male population. So giving us maybe some idea about the different lifestyle when it comes to gender. This is a national health survey that was conducted in the UAE, comparing data from 2010 versus year 2019. They surveyed 9,400 Emiratis, and according to this survey, adult obesity has decreased over that span of 9 years. And so has the number of adults reporting to have diabetes. But this is a self-report survey. And if we look at the very bottom, at the adults with high blood pressure, you can see that the prevalence here, or the reporting, has doubled from 2010 to 2019. So just interesting observation. And I'm pretty sure that after the year we just had, the numbers would be pretty interesting to look at again, and we would probably see a rise. What about in childhood? So according to several studies in the UAE, overweight or obesity is affecting about 20% of the 5 to 10 years old, about 40% of the 11 to 18 years old, and about 1/3 of all children in the UAE. So this is definitely a serious problem. So as I promised, a word about COVID. So we know that children are also susceptible to catching COVID, but that fortunately the majority will end up only with mild illness. However, in the studies that have looked at the clinical characteristics of children that were hospitalized with COVID-19, and looking specifically at the underlying condition associated with these hospitalization, obesity ranked number 1 in this study from the United States. So here they were looking at a large sample, out of which 42% had comorbidities, and obesity was the highest on the list, with about 38% of these children being obese. So there is also the other side of the coin, which is that with the strict measures that we've all had to comply with over the past year, the rate of obesity has increased, but it has been specifically more difficult on the children who were already struggling with that. And there are many reports on the topic in the literature. This is specifically one from Italy published very early on in a country that had a very strict lockdown from the get-go about the effect of COVID-19 lockdown on lifestyle and behavior in children with obesity in Verona, Italy, and I quote, COVID-19 lockdowns worsen childhood obesity. Obese kids under lockdown in Italy ate more junk food, watched more TV at the expense of physical activity. So what about, what are the risk factors, the preventable and the non-preventable? So both low and high birth weight are risk factors for developing obesity later on in childhood. A rapid weight gain in infancy, or a rapid catch-up growth, especially in the SGA kids by the age of 2 years, put the child at increased risk of developing obesity. Parental obesity in itself is a risk factor with increased odds ratio. So if you have parents who are overweight, your odds ratio are about 2. And with obese parents, we're talking about 2.5 to 3.5 increased odds of the children developing obesity. Excessive screen time, which is becoming more and more difficult to avoid, and inadequate sleep. A lot of children are staying up very late on screens, which is promoting late night eating, unhealthy snacking, and increased insulin resistance. So I just wanted to point out here that classically we know that SGA and rapid catch-up post-SGA is an increased risk, even if the weight in children remains normal. SGA children may have increased visceral adiposity, which will predispose them to increased cardiovascular risk. But also the LGA, so the large for gestational age, who don't have adequate catch-down growth because of the persistent high weight since infancy, will also be, seem to be at least, at increased risk of adverse cardiometabolic outcome as adults. So it is really very difficult, and it is becoming more and more difficult in the society we live in to curb down obesity. And that is why the prevention of obesity and tackling the healthy lifestyle and educating parents about healthy lifestyle from the get-go before the onset of obesity should be the primary goal of us as healthcare workers when we see children for routine visits, in order, because achieving long-term lasting effect with lifestyle modification once obesity sets in is very, very difficult and challenging. So going back to our patient Khaled, he had some additional blood work that was done. He had an elevated total cholesterol, elevated triglyceride, a low HDL with an elevated LDL. His ALT was also elevated at 50. So our first line of action when it comes to these patients are lifestyle interventions, and one of the mainstays of lifestyle interventions are dietary modification. And this is where the role of the dietitian on the team becomes very, very important in educating not only the child, but the entire family to adopt these healthy eating habits. So we need a diet that is high in fiber, with reduced fat intake, especially trans fats, which have been shown to be strongly associated with adverse cardiometabolic outcomes, and a low glycemic load diet. Essentially, the Mediterranean diet, which is rich in fruits, vegetables, low-fat milk products, whole grain, fish, poultry, nuts, and lean red meats, and that is poor in sugar, sweet, and sodium. Sodium for the hypertension part. And it's important also to emphasize that in children, because they are still growing, sometimes halting weight gain in of itself will be sufficient to prevent the development of the complications that we have mentioned. So when it comes to dyslipidemia, there are additional points that need to be taken into account. Again, important to have a dietitian on board here, because you need to restrict saturated fat to 7% of the total calories. You need to reduce the dietary cholesterol intake, focus on soluble fiber, which will bulk the food when they're in the stomach. They will slow down digestion and have been associated with lower cardiovascular risk. And these are found mostly in seeds, in beans, lentils, oats, and nuts, and also increase the intake of fish and omega-3 fatty acids. The other part of lifestyle intervention includes physical activity. So the recommendation is to do at least 20 minutes of moderate to vigorous activity with the goal of reaching 60 minutes a day. Low aerobic and resistance exercise. We used to say that resistance exercise may have a negative impact on joints, on growth, and all of these things. But actually, the newest recommendations say that in youth who are overweight or obese, starting some basic resistance activity is actually more successful on the short and long term when it comes to adherence, because it helps them build strength and it doesn't require stamina, which they tend to lack with the excess weight. The AAP also recommends a maximum of 1 to 2 hours per day of non-academic screen time. I don't know how. I think we're really failing when it comes to this, especially now kids are e-learning, but they're also doing other things on their computer. And finally, sleeping habits, as I mentioned earlier, late hours, not getting enough sleep. And always remember to ask the question about snoring, about breathing interruption, because this sometimes goes unnoticed and is not necessarily brought up by the family or by the parents. So the exercise benefits are not only limited to weight loss, they include increasing the HDL, lowering triglycerides, improving insulin sensitivity, in addition to the positive effect on mood with reduction of depressive symptoms and improvement of bone health. But as we know, there are several obstacles to successful weight management. The lack of access to outdoor areas. We've had the lockdown, we have the summer coming up, transportation, finances, balancing with schoolwork, concern about negative interaction, bullying that kids are subject to, the physical discomfort of conducting a physical activity, and very important, the thought that healthy eating is a temporary fix, that I'm going to lose weight and then I can eat whatever I want, versus understanding this as part of a long-term commitment for one's health. So what are some of the things that we can use to actually implement these changes as part of a long-term strategy rather than a point in time intervention? Motivational interviewing is one of the techniques we can use. So this is a semi-structured interviewing technique to offer space to the patients to explore their feelings and kind of set their own goals. We need to be on the lookout for a change talk. What motivates this child? What will drive them to change? And we need to help them identify these motivating factors. And once we have done that, we need to help them set what we call SMART goals. Because I can say I want to exercise every day, but this is very vague, very non-specific. It's not really measurable. And if I've never exercised before, I'm unlikely to stick to it. Versus if I say, for the next 2 weeks, I want to take an exercise class for at least 30 minutes every other day. This is specific, measurable, it is attainable, it is relevant to my goal, and it's time-bound. After 2 weeks, I can reassess and reevaluate whether this is working for me or not. So, going back to Khaled again. So Khaled tried the lifestyle intervention. He was seen by a dietitian. He tried to exercise. Unfortunately, his weight kept going up and his BMI continued to increase. His labs worsened. His HbA1c was now in the diabetic range, with also persistent dyslipidemia. So what are our options in terms of pharmacologic treatment? When it comes, until recently, when it came to obesity itself, we didn't have very many options. We still don't have very many options, actually. So orlistat was the only, actually orlistat and phentermine were the only FDA-approved treatment, but because of the steatorrhea, there was a lot of poor compliance, and really, we don't really use it in children. And the European Agency for Medication doesn't have any approved medication for treatment of obesity in pediatrics. When it comes to insulin resistance and obesity, again, no FDA-approved treatment here. Metformin has been used but it is used as off-label. In adults, it has shown to decrease the risk of developing diabetes. It is, however, approved, metformin is approved in children with type 2 diabetes above the age of 10. And it has been shown to reduce ALT in NAFLD. We do have one new treatment that is now approved by the FDA for the treatment of obesity in the pediatric age group starting age 12, which is liraglutide. It's a GLP-1 agonist that increases postprandial insulin level in a glucose-dependent manner. It reduces glucagon secretion, delays gastric emptying, and induces weight loss reduction by reducing appetite and food intake. So this is now approved for use in adolescents. And in this study that was published last year, it shows that when they used liraglutide versus placebo for a period of 56 weeks, they saw a significant reduction in BMI and BMI standard deviation score, as well as in absolute body weight in the children who were on treatment. What about treatment for pharmacologic treatment for dyslipidemia? So we treat children who are above the age of 10. If after 6-month trial of lifestyle modification, we continue to have an elevated LDL, so an LDL greater than 190, or if they have other risk factors such as obesity or a family history of early cardiovascular disease, then 160 is the cutoff. And if they have diabetes, whether type 1 or type 2, then the cutoff will be 130. The available treatments really are statins and fenofibrates. For hypertension, just keep in mind that there are different stages, and that for ages less than 13, we use percentiles. Above 13, we use absolute number cutoffs. And again, here, the recommendation is to start treatment if you don't see reduction after 6 months of lifestyle interventions, or in a child who has symptomatic hypertension or any stage of hypertension associated with diabetes or chronic kidney disease. There are several first-line agents, all with their side effects that we need to watch for: ACE inhibitors, ARBs, thiazides, and thiazide diuretics, which can be used as an add-on to the first two if control is not managed, and calcium channel blockers. So Khaled based on his presentation, was started on metformin, which was increased gradually to reach a dose of 1,000 milligrams BID. And he was also started on atorvastatin 10 milligrams, which can also be titrated up if needed. So finally, a word on surgical interventions. Bariatric surgery is approved for adolescents between ages 10 and 19 if they have a BMI greater than 35 with severe comorbidities, or if the BMI is greater than 40, even with less severe comorbidity. There is always a worry about recommending surgery in the pediatric population. However, watchful waiting is not always the best strategy. So the latest statement of the AAP on the topic is that the pediatric patients with severe obesity are unlikely to achieve a clinically significant and sustained weight reduction based on lifestyle only. And sometimes watchful waiting will actually worsen their BMI and kind of put us in a more difficult position when it comes to treatment. And also, studies have shown that intervening surgically at a lower BMI below 55 has a higher probability of achieving a non-obese status compared to starting at a higher BMI. Of course, this needs to be done as a part of a multidisciplinary team. You need to have a dietitian involved, a psychologist involved, pre and post-op. You need to watch for micronutrient deficiencies. So it is really not a light or easy business to undergo bariatric surgery. So Khaled, in summary, presented with obesity and insulin resistance and ended up developing type 2 diabetes. He also had dyslipidemia and hypertension. So do you think he's a candidate for bariatric surgery? That's the question. And thank you very much.
Thank you, Dr. Mireille. It was a very nice presentation, and I mean, it's a need of the hour. Everyone has concerns about such children. There are so many questions, and unfortunately we have just 2 minutes to wind up the session. I'll just ask you one question about the age when you would start screening these kids for the metabolic syndrome. And what criteria would you use?
So any child who comes to any clinic visit should have their weight, their height, and if they're less than 2 years of age, their weight for length plotted. If they're above 2 or 3 years of age, they should have their BMI plotted. And as I mentioned in the talk, we want to intervene, we want to start educating before the child reaches the obesity point. So any visit is a good visit to screen for obesity and metabolic syndrome in a child.
When would you start doing blood tests to look for the cholesterol and?
I'm sorry?
When would you consider doing blood tests for these children?
Okay, so it wouldn't be, it depends on the age really, and it depends on the severity. So I would start initially with the lifestyle. If, we have a child that is mildly overweight, there is no significant family history, then I would start with the lifestyle intervention. I would start with education, with dietitian referral, and with these things. And kind of take it from there. If I have a child with excessive, with severe obesity, a very significant family history, then I may start right away with the labs.
There's no age cutoff for when you would do the labs.
I'm sorry?
There is no age cutoff for when you would consider doing the labs. It's just a severity.
No, it's really on a case-by-case basis. I would do it based on each patient's presentation.
Again, I mean, you mentioned about the COVID pandemic, and when we see so many parents who are coming back obese, who are supposed to set an example for their children, you can't blame the kids themselves. I mean, I'm seeing so many families where the parents have become obese during this past year.
Exactly. It's been a challenge to everyone, to all of us. And I tell the families, I understand. I understand it's been difficult for all of you, for all of us, but we have to start somewhere. And if the more the whole family is involved and convinced, the more we are likely to achieve some good results. Because sometimes we do. We do have this kind of defeatist attitude when it comes to lifestyle, sometimes maybe because we see it fail a lot, but there are success stories and there are children and families who have turned their lives around.
Great. Thank you so much for a very important topic and well presented as well. Can I request you to answer some of the questions by typing the answers to the participants because we are run out of time. I appreciate your participation and thank you. So that